we go to PFT, pulmonary function test. Is it visible?
Yes, sir.
So here also there are some of the questions which you have to answer first. So how to perform pulmonary function test? What are all the things that you have to know to perform pulmonary function test? A thorough history and examination is essential before you go to do the pulmonary function test to assess the true clinical picture of the patient. Okay. So patients' exercise tolerance also demonstrate their functional ability. So these things should be either inquired with the patient or should have been documented. The third thing is measuring oxygen saturation before, during, and after a stair climb can help in assessment of the lung function before you do the pulmonary function test. And the history of chronic sputum production, the ability of the patient to cough indicates that he has a good vital capacity. So if the patient is able to cough out the secretions in the respiratory tract, it means he has a good vital capacity. The very term vital capacity indicates the ability to keep your respiratory tract clear of the secretions which are inherently produced or preventing an aspiration. So that is the main function of your vital capacity. Pulmonary function tests are divided into two categories. One to assess the ventilation and the second is to assess the gas exchange. Just like the pH, the ABG is done to assess the oxygenation and ventilation. Here, pulmonary function test, we are doing it mainly to assess the ventilatory component and also the gas exchange component. So, exercise tests also assess the cardiopulmonary reserve of the patient. And what are the indications for pulmonary function tests? This you should be able to answer. What are the indications? When will you refer a patient to have the PFTs done?
Lung reduction surgeries.
Preoperative assessment of thoracic or lung
Obesity
disease.
patient.
Very good. So, diagnosis of the disease process. Whenever you are in doubt whether it is an obstructive disease or a restrictive disease or a mixed disorder, when you cannot make it out clinically, you can do a pulmonary function to diagnose the disease, number one, or you can do it to assess the response to the therapy. When you put a patient on bronchodilator therapy, you can see do the pulmonary function test before bronchodilator and then the post bronchodilator to see the response. Or you can document the course of disease. For example, a patient with COPD, you can do periodic pulmonary function test to see whether he is remaining static in the same situation or he is worsening by assessing the pulmonary function. And you can do it as a preoperative assessment before lung resection or cardiac surgery or non-cardiothoracic surgeries. Or you can use it for evaluation of the disability of the patient. Lastly, you can do this for evaluating the prognosis. So these are all the indications: diagnosis, response to therapy, follow up the course of the disease, preoperative assessment, evaluation of disability, and evaluating the prognosis. Now, how do you assess the ventilation? I told you this is divided into ventilatory assessment and gas exchange assessment. So, what are the tests that are indicated or done in PFT to assess the ventilation? Most important component.
Spirometry, sir.
Spirometry part, but more than that. Movement of the air, how it is measured.
Expiratory flow rate.
Peak flow.
Peak flow.
This is a very important measurement that will decide whether the air is able to travel easily from the atmosphere into the lung and back after exchange. Okay, it measures the peak expiratory flow rate during forceful expiration from vital capacity. That is, after a full inspiration, you ask the patient to blow out as forcefully as possible. So the main peak flow is follow the course of main role is to observe the course in obstructive disease or COPD, and it may be useful in during exacerbation condition to assess the response to treatment also. Okay, and the value is assessed in comparison to the previous results or predicted value calculated using the patient's sex, age, and height. Okay, so these are the three things that are taken into consideration in any PFT. And the normal diurnal variation of peak flow will be lowest during the early hours of the morning. So all these tests have to be done quite late in the day, not as soon as the patient wakes up in the morning when the values are likely to be low. So peak flow is mainly done to rule out any obstructive airway disease, so that to know whether the patient has capacity to blow out the air out of the lung. Now coming to the gas exchange, which test is important for gas exchange?
Diffusion of
carbon.
Answer factor, PLCO or
DLCO.
PLCO. Okay, and also it is also called the diffusion capacity for carbon monoxide. Why carbon monoxide is taken as a gas to assess the
It is more diffuse than CO2, sir.
diffuse are more attracted by hemoglobin.
binds more avidly to hemoglobin than precipitated more than
Using a single breath mixture of 10% helium and a concentration of 0.3% carbon monoxide. Patient holds the breath for 10 or 20 seconds and then exhales. This is the procedure how it is done. And carbon monoxide, because of the high affinity for hemoglobin, it has got 250 times more affinity than your oxygen. That is why in smokers you have this carbon monoxide occurring. And maintain low partial pressures in the blood so that it is taken up immediately, diffuses across the alveoli. What are the conditions where PLCO will be reduced?
parenchymal diseases.
Parenchymal diseases, very good. So impaired diffusion, increased thickness like lung fibrosis, or decreased area after lung resection or emphysema, and reduction in the ability to combine with blood. Even anemia can reduce the TLCO, and it is adjusted for alveolar volume, that is termed as transfer coefficient, KCO. So TLCO and KCO are reduced in similar amounts. The disease prognosis, if both are reduced in the same amount, then you can make a diagnosis that the disease process is uniformly or homogeneously present throughout the lung tissue. On the contrary, if TLCO is reduced more than the KCO, that is the transfer factor, then some areas of the lung have relatively normal preserved function. For example, like smokers and those with emphysema. So these are the two major classifications or purposes for which we do the PFT. And how is spirometry done? What parameters are measured using spirometry? All of you have seen in some workshops or CMEs how spirometry is being done.
So we have to instruct the patient to take deep breath and they have to blow.
What instrument we use?
Spirometry.
The
Spirometer.
spirometer. It is called vitellograph. Okay, it's called a vitellograph. We measure FEV1 and FVC mainly. These are the two parameters that we measure. Okay, and advanced equipment is needed for other information. So we can also, by using this advanced laboratory equipment, we can measure forced expiratory flow at 50% of vital capacity, as well as the flow rate between 35 and 75% of the value, which is more sensitive to detect airflow obstruction in the early disease. The reduction of post expiratory flow of the 50% indicates small airway diseases like example of small airway disease is
Asthma.
asthma, bronchial asthma. Why so much of hesitation? Okay. So what volumes and capacities cannot be measured by spirometry and how are they measured?
Residual
Residual
Volume and
total lung
Total
capacity.
Total lung capacity, FRC. These are the three things because it's a very common question in the exam. They will ask you total lung volume or total lung capacity, functional residual capacity and residual volume are the three parameters which cannot be measured in the spirometry. So it is has to be done by using what is called body plethysmography. That is the equipment that is required. What is this? What is shown here? What parameters can be measured using this?
Peak respiratory flow rate.
This is not a peak expiratory flow rate measuring equipment.
Right spirometry.
This is called Wright's respirometer. Okay, so this is the Wright respirometer which can be used at the bedside. And tidal volume and vital capacity are the two measurements that can be made. We can just attach a mask or a mouthpiece with a corrugated attachment tube to the patient and ask him to breathe normally. And you can, what are these two buttons here for? Have all of you seen this equipment live?
No, sir.
No,
No,
not
sir.
seen. Okay, only in pictures. Okay. So this used to be the instrument we used to use at the bedside as postgraduates and assistants in late 80s when pulmonary function labs were not available. Okay, so this one button is to reset. You can see there are two markings here. One outer marking, another inner marking with two different needles. Okay, pointers. So the outer one measures the tidal volume. This is in 100 ml, 200 ml, 300 ml or 0.3 liters, 0.4 liters like that. So you can measure the tidal volume by using the outer marking and the vital capacity will be in liters. So that can be measured using the inner cycle. So one button, if you press, both will come to 0. And then you attach the mask and keep the thing on the patient's face. The other button is for on off. So once you press this, it will start recording. Then you press it again, it will stop at that level. So one button for resetting it to 0, other button for on off, and you can use it by attaching a face mask like this and putting it onto the patient's face, or you can use a mouthpiece and ask the patient to blow through this and record that. Okay. So which one do you think will be better? Which method of using? That's logical thinking. When if you have not used it.
The first one will have less leak than the face
Fantastic.
mask.
Which one is better and why? Because mouthpiece is better because patient can tightly cup his lips over the mouthpiece and it avoids leak. Okay, that is a good thinking. What different tests comprise PFT? So many things you are doing.
Pulmonary.
If you think that you will straight away be shown only the PFT report and ask you to interpret, there are 6 different tests you can do. Spirometry, pre and post bronchodilator, low volume loops, lung volumes, diffusing capacity, and bronchoprovocation challenge test. Okay, these are all the things that can be done in the pulmonary function lab. What are the limitations of PFT? Why we don't perform PFT that often, like you do ABG or an X-ray or ECG? Because there are a lot of limitations. One is how they are interpreted. There's a limitation in that. 2, a knowledge whether the PFT is reliable to interpret. Just like the internal consistency I told you about ABG, whether the PFT has been properly done or not, and whether it is reliable is also very, very important. And it should be the person who is doing the interpretation should have an organized approach to interpret the values. And referring values in PFTs are not absolute cutoffs. See, always you have a actual measured values compared with the predicted or a standardized value in PFT reports. So these standardized or reference values are not absolute cutoff values. So that is the reason why PFTs are not that much dependable. Even though you can get a gross idea about the disease condition, it is not done that frequently, except in cases of asthma where pre and post bronchodilator measurements will help to treat the patient with an appropriate bronchodilator. So the significance of post BDR response, how it is calculated, is also very important. Either the FEV1 or FEC, if it improves more than 20% of the predicted values, that means it is a good bronchodilator response. The equation that we use to calculate our post BDR predicted value, that is the lower limit, and the pre-BDR predicted value, and that is in liters rather not in percentage, in liters, multiplied by 100 divided by predicted FEV1 by FEC in liters, then you get the BDR response. Now, actual bronchodilator response predicted in liters and not in percentage. That is a very important thing that we have to remember. Now, just like the steps in interpretation of ABG, what we saw, like you start from the pH, then go to PCO2, PO2, decide acidemia or alkalemia, and if it is acidosis, respiratory composition, if it is alcohol, metabolic, the respiratory composition. Just like that, there are steps in interpretation of PFT. Okay? First thing is, what is the clinical scenario of the patient, and look at the demographics. Like what I said for the ABG, look at the patient name, age, etc. And whether you can rely on the PFT or not depends on three factors. Can anyone tell me what are the factors which will tell you that a PFT is reliable or not? Anybody who has studied about how to depend or rely on the PFT values? Any idea? The first one is the volume time curve. All of you know how a volume time curve is plotted? All of you would have seen that in the books, isn't it? The expiration should last at least 6 seconds when you do the volume time curve. This is how the volume time curve looks like. This is the normal curve. You can see the patient starts breathing out, and after initial rise in the volume, it reaches a plateau, and the expiration or the exhalation goes on up to 6 seconds in a plateau fashion. Whereas if the volume time curve goes like this, keeps on increasing without achieving a plateau after initial rise, this is not reliable. So the first thing you must do is plot a volume time curve and see whether the exhalation lasts for at least minimum of 6 seconds and it achieves a plateau. Whereas here you can see it is going on increasing. It is not in a plateau. It is not in a straight line. So this is unreliable for a PFT interpretation. The second thing is the two best efforts. You always do 3 attempts or give the patient 3 chances to perform the same test every time. When you want to measure the FEV1, you have to take 3 measurements and take the best out of 3. Similarly, when you do the FEC measurement, you have to give 3 chances and take the best out of 3. So like that, every time you have to do it 3 times, and when the 2 best efforts should be less than 0.2 liters difference. For example, FEC, first attempt it is 3.4 liters. Second attempt it is 1.8 liters. Third attempt it is 3.17 liters. If that is so, it is not reliable. So the maximum difference should be only 0.2 or 200 ml between the best two efforts. Then only it is reliable. For example, like this, you can see 1, 2, 3 attempts are there. In the FEC calculation, the predicted value is 3.6 and the best effort is 3.04. So he has already done as a predicted of 83%. And when you do that, you can see these two values are less than 100 ml difference, 2.93 and 2.94. So this is a reliable method or reliable PFT. So these two parameters or three factors have to be looked into. And the third is flow volumes are free from artifacts and abnormalities. So if all these three criteria are fulfilled, then that PFT is quite dependable and you can go ahead and interpret that. So this is the basic thing that we have to understand. And the first step is to, after making sure that it is a reliable PFT, first thing is you always look at the FEV1 to FEC ratio, whether it is low or normal. And if it is low, look at the FEC value also. That is also low. Then confirm whether it is a restrictive or obstructive pattern by looking at the total lung capacity or total lung volume. Okay, these three things only are going to play the main role in interpretation of your PFT. FEV1, FEC, and total lung capacity. So conditions where this is very low, there is an obstruction because patient is not able to exhale. Normally 83% of the vital capacity, he should exhale it in the first second itself. That is what is called the forced respiratory volume in 1 second. If he is not able to do that, that means there is an obstruction to the flow. And then grade the severity of the abnormality, like mild, moderate, severe, very severe. These are the 4 grades that you can grade it based on this value. Then determine the reversibility of the obstruction by treating the patient with the bronchodilator. Then sometimes in doubtful cases of bronchial asthma, you may have to do a bronchoprovocation test. So just know this terminology, but this is not commonly practiced. Like you have to stimulate a bronchospasm and see how much is the reduction and then treat it with so this is a test which was originally done but now not very much recommended. But from exam point of view, you have to just know this and establish a differential diagnosis and compare current and prior PFT results. And to, last one to be added here, which I have not added, is the diffusion capacity using the DLCO in some cases where these things are all normal, but still the patient is hypoxemic. Okay, so in that situation, you have to do the DLCO or CLCO result also. So with this basic thing, first foremost commonest thing that the examiners or the PFT reports that are given to you will show either an obstructive pattern or a restrictive pattern or a mixed pattern. Okay, so what are the things that you have to look into? As I told you, these 4 things are very important. Forced vital capacity, forced expiratory volume in 1 second, and the ratio between these two, and total lung capacity. If you know these 4 things, how to interpret them, you can differentiate between an obstructive pattern and restrictive pattern. Now, can you tell me what will be the values in obstructive pattern if and you measure these things? What will be the FVC in obstructive disease?
It will be high, increased
It will
in
be
increased in
high or
obstructive pattern.
normal or high?
Normal or high.
What about FEV1?
Decreased.
Reduced.
This ratio
Ratios decreased.
is also decreased. And total lung capacity
Normal or
normal or
increased.
So that is the obstructive pattern. Whereas in restrictive, how do you differentiate between obstructive?
FVC will be low. FEV1
FP1 is
will be low.
increased.
The ratio will be normal or
Normal. More or
It will
less
be
normal, even sometimes better
Other
than
low.
this one. And TLC will be
reduced.
reduced. Okay, so that is how you simply make out. So if you see, FEC is either decreased or normal in obstructive pattern. Restrictive is definitely reduced. FEV1 is definitely reduced in obstructive because their patient is not able to breathe out comfortably. And in restrictive, it may be slightly decreased or normal. But this FEV1 to FEC ratio, that is the game changer. This is the one which determines whether it is obstructive or restrictive. So FEC1 to FEC will be decreased definitely in obstructive, it will be normal. And TLC is the next one. It may be normal or increased in obstructive, but it will be definitely decreased in restrictive pattern. So if you see a normal FEC, F1, FEV1, FEC ratio with a decreased total lung capacity, it is restrictive pattern. You see a decreased FEV1 to FEC and a normal or a increased total lung capacity, it is obstructive pattern. See, that is the basic, easiest way to remember that. So how to interpret the PFT in different diseases? So interpretation, these are all the things, common terminology. It can be restrictive lung disease, where as I told you, PLC is less than the lower limit of normal. And FEV1 to FEC ratio is preserved or it is normal. I told you here. Then there is a mixed disease, obstructive and restrictive pattern. That is the one which may sometimes be confusing, where you will have the FEV1 to FEC ratio, which is lower than the normal limit, plus TLC is also on the lower side. So if that is the case, it may be a combination of both. So TLC is the determining factor there. If TLC instead of being normal, if it is decreased with a decrease in FEV1, then you have to think of a combined mixed disorder. And there is a condition called air trapping, where the residual volume is on the more than the upper limit of normal, or with a normal TLC or RV to TLC ratio is also increased. Then there is another condition called hyperinflation, where FRC and or TLC are both are on the upper limit of normal, and there is a non-specific pattern. This is the one sometimes given in the exam may pull your legs, where FEC is low, but FEV1 to FEC ratio and TLC are both normal, and that is called the non-specific pattern. So these are the 5 different types that you have to remember. Restrictive, of course, obstructive also you know. So in mixed disorder, air trapping, hyperinflation, and non-specific patterns. Now we go to the actual testing of pulmonary function test. This is the value that is given. A 29-year-old one presents with the episodes of shortness of breath, chest tightness, wheezing during springtime. The to interpret her PFT as these are the options, whether it is normal, obstructive, restrictive, or mixed disorder. So you can see the actual measured FEC is 4.39. The predicted FEC is only 4.32. So it is more than predicted value. So the percentage of change is 102%. And FEV1 predicted is 3.37 and actual is 3.2. So it is almost 95% of the percentage change. The ratio is predicted is 7.8. The actual is 0.73. And FRC is almost equal. Residual volume is almost normal. TLC is also almost normal. So what is your inference in this case?
Mild obstructive.
Mild obstruction.
Normal, sir.
Yes. Why you always think of pathological? Okay. So FVC is normal. FEV1 to FVC ratio is normal. TLC is normal. So this is a normal spirometry and normal lung volumes. Okay. So always don't go with the idea that there should be something wrong in the PhD reports given to you. That is the reason why I have started with the normal one. Now there is a, based on the lung function test, the suspicion, there is a decrease in normal lung function that rules out asthma. And her clinical history suggests you, but she is complaining of shortness of breath and chest tightness and wheezing. So whether bronchodilator response was not assessed, so we do not know. So these are all the things. So what are all the things that you should do in this patient to rule out asthma? Spirometry, both pre and post bronchodilator should be done. Normal spirometry does not exclude the diagnosis of asthma because it may be occasional. The additional steps to asthma, that is bronchoprovocation tests like methacholine, cholinergic challenges, can be done if the patient is very insistent about getting rid of that shortness of breath. Okay, otherwise this can be dismissed as a normal spirometry. Now this is a second case scenario where you have all these values. So the options here are again normal, obstructive, restrictive or mixed pattern. So taking the FVC value, the predicted value is 5.03, but the patient's best effort gives only 3.05. That is reduced to only about 58% of the predicted or the standardized value. FEV1 is also quite low compared to the 3.9, which should be the actual predicted amount. It is only 1.65, 42%. FEVC to FEV1 ratio is also very much reduced. So we will ignore all this FEVC1. Lung volume, TLC is also reduced. Out of 8.17 predicted, it is only 5.9. So what is the diagnosis? TLC also is given, but we will not go into that. Based on these three things, what is your diagnosis?
Restrictive
FVC
pattern.
low, restrictive pattern, right? FEVC, FEV1 ratio is all reduced. Why do you say restrictive? Because of the
Total lung capacity is reduced.
reduced, but this is also reduced. So
Mixed obstructive and restrictive.
so it is a mixed obstructive restrictive pattern. Okay, the FVC, FEV1 ratio both are reduced and TLC is also reduced. That is the one I told in the last thing about the previous slide I showed you. No? So if both TLC is also reduced along with the FEV1 and the FVC, should be a mixed obstructive restrictive pattern. Okay. So here the reason for that is low FVC, FEV1, FEV1 to FEV percentage, TLC, all are low. So this is a mixed obstructive restrictive pattern. The second one, we have a PC, which is again low, FEV1 again low, FEV1 to FVC ratio, which is again low. TLC predicted is 6.43, but best is 8.74. That is, TLC is higher than the prediction value. What is your options are the same: normal, obstructive, restrictive, mixed. Why so much time? TLC is higher, FVC and FP1 ratio are all low.
Obstructive.
Why so much delay about that? See, this is obstructive pattern. Okay. The reason is low FEC, low FEV1, low FEV1 to FEC ratio, but normal or high TLC and residual volume is also higher. You can see the predicted is only 2.44, but the actual is 6.04, 247% increase. TLC 136% increase. Okay, so this is classical obstructive pattern. Now these are the flow volumes I am showing here. What is this green thing? And what is this blue line? You can see the wordings also here, VT. What does VT mean?
Tidal
volume.
Tidal volume. Inspiratory and expiratory tidal volumes have been plotted here. Okay, small normal breathing. But when you do a flow volume, what do? You do a forced inspiration and expiration. Okay. So this green is the normal tidal volume, and blue is the vital capacity maneuver, where you do the plot the inspiratory and expiratory things. Okay. And in this A, you have the small airways unit explorers, and B shows the scooped out appearance. This is the normal, this is the scooped out appearance. And what about, so this is classical obstructive pattern
obstructive.
of the flow volume loop. What about this? C,
Restrictive.
Restrictive.
huh? Restrictive. Restrictive should be a miniature version of this normal. Then only it is, supposing this is only like this, half the size.
Upper airway
FEC
obstruction, sir.
This is a fixed large airway obstruction, either intra or extrathoracic, causing poor flow both during expiration and inspiration. Okay? So this is a fixed large airway obstruction. What is this? The first slide I told you, you have to assess the volume time graph or plot. So what are the three lines showing here? What is the blue line? What is the red line? What is the green line?
Blue is normal, sir. Red is restrictive lung disease. Green is obstructive lung disease.
Fantastic. Very good. So this is the idealized post-expiratory spirogram, that is volume time curve of a healthy subject, which is blue, normal, airflow obstruction, that is green. The patient is not achieving the FEV1, but his total volume is achieved, but it takes a longer time. Whereas in restrictive pattern, he is also not able to achieve the FEV1, and his FEC also is not able to achieve. So the ratio becomes normal. Whereas here, the FEC is larger and the FEV1 is shorter. So the ratio becomes inadequate. So these are the three conditions: normal, restrictive pattern, obstructive pattern. Okay? So in obstructive pattern, expiration is prolonged and theoretically reaches a normal FEC by taking longer time. And in restrictive pattern, normal vital capacity is not achieved at all. The FEC is not touched. Okay, so that is how these three graphs have to be interpreted. Now, these are again the spirograms: 2 volume versus time and 2 volume versus flow. Okay, these are the volume time, these are the volume flow curves. Which of the 4 are normal, which are abnormal?
The top left is normal, sir.
Top left is normal.
First
Now,
one.
what about the top right?
Obstructive pattern,
So
sir.
normal flow volume.
So the 2 top are acceptable. Both are normal. The bottom, the right, left one is there is a stoppage before it reaches the full volume. Okay, there is a stoppage, And here the patient has coughed between, so it is not able to complete the total volume that is being there. Now the case scenarios, some of the case scenarios where it can be challenging. A 64-year-old woman presents with complaints of dyspnea and orthopnea. She is a lifelong non-smoker. Her pulmonary function tests are as follows. FVC actual is 1, but predicted is 2.5. That means there is only a 40% of the predicted FVC. FEV1 is also only 30% of predicted. PLC is 50% of the predicted. So, and patients, they have measured the FVC and FEV1 in upright and supine position also. So with this clue, what is your diagnosis?
Restrictive lung disease.
Restrictive airway disease.
Restrictive. See here, FVC, FEV1, FVC are all reduced. Why do you say restrictive? See, these primary three values, they are all only 40%, 30% of the predicted. The ratio is also out of 80% predicted, it's only 61. So how do you say it is restrictive? Because the PLC is also low. Do you say it is restrictive?
Mixed.
Mixed disorder. Why you are hesitating like that? See, when the PLC is also low along with the reduction in FVC, FE1, it should be a mixed disorder. So the patient has a reduced FEV1, FEC with a reduced this thing, therefore classified as an obstructive defect. However, she has a low TLC also, which is an evidence of restrictive defect. So this should be termed as a combined obstructive restrictive defect. Now a DLCO is not provided, which makes it difficult to determine if the cause of restriction is due to pulmonary parenchymal process or an extrapulmonary process. Now with the history that it is being done in upright and supine position, what does it, why do they do it? If they lie supine, gravity no longer exerts an effect on the diaphragm and abdominal contents, and patients have trouble getting their diaphragm to descend against the abdominal content. So the presence of diaphragmatic weakness is confirmed by repeating a pulmonary function test in upright and supine position. And that is how you found that it is also having a restrictive element. Okay, so this is a restrictive mixed disorder. And how to find the validity of this particular function test is if the FEV1 to FVC measures are within 200 ml of each other during the last two best efforts, then it can be considered as a eligible criteria for accepting this PFT. As I told you in the first beginning itself, there are three factors that you have to take into consideration. One is the volume time curve. Second is the maximum difference of less than 0.2 or 200 ml between two best efforts, and the flow volume group should not have any artifacts. This is the next case. A 73-year-old man presents with progressive dyspnea on exertion. He reports a dry cough, but no wheeze, no sputum production, fever, or hemoptysis. He's a lifelong non-smoker, worked as a lawyer until retiring 3 years ago. He likes to hunt and fish. His pulmonary function tests are FVC. It's only 35% of predicted, quite low. FEV1 is also low, 38%. FEV1 to FVC ratio is normal. Actual is 82, predicted is only 36. And TLC is very low. Very easy to diagnose. What is the answer? Taking so much time. Are you all there?
Mixed only, sir.
Why mixed?
Restrictive.
Both FEV1 and TLC is low.
See, the ratio FE1 to FEC is normal, yeah. These three are reduced, and TLC is also reduced. It's only 2.7. Predicted is 6.45.
Restrictive
Classical
pattern.
restrictive pattern. See, this is a FEC all reduced. So the patient has a idiopathic pulmonary fibrosis, and it's a restrictive lung disease with diffusion defect because of the TLCO value is also given. It is grossly low compared to the 31.64% of predicted. It is only 16. Okay. So, are you all not able to understand? There's something wrong with my teaching. Only three things, ma. One is obstructive, another is restrictive, third is mixed. So FEC low, FE1 low, FE2, FEC ratio normal, and TLC low, it is restrictive. FEC low, FEV1 low, FEV1 to FEC ratio very low, TLC is normal or raised, obstructive. And if the TLC is low and all the other things are also low, it is a mixed disorder. Simple. Very,
Yes.
very simple to understand. Okay. So 44-year-old woman with cirrhosis secondary to chronic alcoholism, hepatitis C presents with complaints of increasing dyspnea. She reports that her dyspnea is worse when she is sitting up or walking, but improves when she is lying flat. She is an active cigarette smoker. On exam, she has a room air oxygen saturation of 88% in sitting position and a room air saturation of 96 in the supine position. Her pulmonary function tests are as normal as below. FEC is almost normal. FEV1 is also 91%, almost normal. FEV1 to FEC ratio is almost 70% of the predicted out of 82. And TLC is also normal, but DLCO is reduced. So what is this condition?
Diffusion.
Diffusion failure, but normal airway.
Yes. Yes.
So this patient has got an ascites. It's a normal FEC, FE1, but reduced FE1 to FEC ratio, slightly reduced, not grossly reduced. Even though FE1 is within normal range, it would therefore be classified as mild obstructive disease. Okay, because of the slightly reduced FE1, and there is no evidence of bronchodilator response, and their DLCO over is markedly reduced. Just 1 second. Chalo papa. Yeah, you take that cetrizine and any cough syrup you have, look at us. You have that. You have that and take that. So this is a case of platypnea. The sign that is orthodiaxia, that is saturation is low in upright and increases in supine position. So this is highly suggestive of intrapulmonary shunt. Therefore, the diagnosis of hepatopulmonary syndrome. Okay. So mild obstructive lung disease with a diffusion defect. That is the final simple diagnosis. 36-year-old woman presents with several months history of dyspnea on exertion and exercise limitation. She is a lifelong non-smoker, no asthma, no pulmonary diseases. She had to stop going out for a weekly running because of no longer keep up with her friends. Her pulmonary function tests are FEVC tool is 0.88, so grossly reduced. FEV1 again reduced. FEV1 ratio actual is 99, preserved, and TLC is low. So what is the diagnosis?
Restrictive lung
Restricted
disease.
patterns.
Restrictive pattern. So this is reduced FEV1 presence, but not diagnosed with it because of reduced TLC confirms the presence of restrictive disease. So based on the fact that TLC is also only 53% of predicted, labeled as a moderative restrictive disease, and essentially has a normal DLC. And the test values are range is considered normal. This suggests that the alveolar capillary interface gas exchange is normal. So how to diagnose what is the cause for the restrictive process is something extrinsic to the pulmonary parenchyma because DLCO is normal. So the patient's body contour is looking like this. Any idea what is the diagnosis? Winging of some pulmonary had a problem of what is called limb girdle muscular dystrophy. Okay? Limb girdle, the swinging of scapula, twisted muscles. So this is called limb girdle muscular dystrophy, which is causing the restrictive pattern. Okay? So moderative restrictive lung disease with normal diffusion. That is the ultimate diagnosis. Next scenario is 53-year-old woman presents with increasing dyspnea on exertion. She has cough, fever, hemoptysis, weight loss, sweats. She was previously an active runner but has now cut back. She is not on occasional chest pain with exercise but has not had any syncope or palpitation. Her PFTs are FPC is almost normal, FEV1 is 84%. FEC ratio is almost normal. TLC is also normal from 4.23 4.36. What is the diagnosis? TLC
Non-respiratory cause.
Huh?
Non-respiratory cause.
So the
Normal.
this pattern is neither restrictive nor obstructive. So it is almost like it's a preserved FEV1 FEC ratio. Yes, a normal total lung capacity. So as there is no evidence either of obstructive or restrictive lung disease. But the patient has a reduced DLCO, indicating that she has reduced alveolar capillary gas exchange. So based on the DLCO, it is a moderate gas exchange abnormality. So this isolated decrease in DLCO with a normal spirometry and lung volume is highly suggestive of pulmonary vascular process such as pulmonary hypertension. So this patient in fact found to have pulmonary hypertension due to chronic thromboembolic disease. So the features of pulmonary hypertension. What are the features of pulmonary hypertension? Any idea? Already she has got some of the things, dyspnea on exertion. So it can be classified into signs and symptoms. Okay, bluish lips, chest pain, fluttering chest sensation, shortness of breath, fatigue, tiredness, and the symptoms are lightheadedness, dry coughing, abdominal bloating, rapid weight gain, swollen ankle or legs. Okay, these are all there. So this is nothing to do with the respiratory mechanics. It is mainly because of the diffusion defect because of the vasculature problem. A 35-year-old previously healthy man presents with dyspnea, fever, chills, and night sweats for past 2 months. He is a non-smoker with no concerning habits and occupational exposure. His PFTs are FEC reduced, FEV1 grossly reduced, FEV1 to FEC ratio grossly reduced, TLC also reduced 51%. This is flow volume loop shows it. This is the scooped out appearance, flattening of second portion of the explanatory unit.
Both restrictive and obstructive.
Both restrictive and obstructive. Okay. So consistent with obstructive process, he has also a low TC indicating a restrictive process. So he would be labeled as having a combined obstructive and restrictive disease. Very good. And this obstructive disease can be classified as very severe based on the FEV1, which is only about 86%. Okay. And there is an interesting finding in the flow volume loop as well. You can see there is a steep component and then a second flatter component on the latter top of exhalation. This pattern suggests that one lung may be emptying faster than the other lung. Therefore, the slow emptying lung might have an obstructing airway lesion. Right? So the picture of his CP and the other thing showed that he has a massive mass which is large enough to collapse the right lung, but also compress the left lung, causing lung restriction. So that is how the obstructive and restrictive pattern came. So this is a mixed obstructive and restrictive disease with also slight, the DLCO is not given, so we cannot comment about the diffusion in this case. It's a 65-year-old man undergoes pulmonary function testing as part of health screening test. He has no pulmonary complaints. He is a lifelong non-smoker. Prior history of asbestos exposure while serving in the Navy. His pulmonary function tests are FEC is almost normal, 102%. FEV1 is 95%. Ratio is almost equal, FEV1 to FEC. Coming to TLC, that is also normal. DLCO2 is slightly reduced, 84%. This flow volume loop like this. What is the diagnosis?
Parenchymal disease, sir.
Normal flow pattern is probably diffusion defect. So the case demonstrates an example of normal pulmonary function test. So all these values are normal up to TLC. Okay, and the flow volume loop also correlates with that, and the patient has a normal total lung capacity, indicating there is no evidence of restriction. Normal diffusing capacity for carbon monoxide, indicating alveolar capillary surface gas exchange is normal. So this is basically a normal PFT. 54-year-old man presents with primary care provider with dyspnea and cough. He is a non-smoker, no relevant occupational exposure. FEC is 76%, slightly reduced. FEV1 is also slightly reduced. FEV1 to FEC ratio is also reduced. And his flow volume loop is like this. Post bronchodilator, there is a good change. 25%, 30%. So what is the difference?
Obstructive pattern, which is improving on giving bronchodilatation.
Asthma.
So FPC, FP1 both are below normal level, defined as 80%. In addition, FPC, FPC ratio is also low, and so the patient has a decreased consistent with airflow obstruction is moderate. And the FEV1 improves by 0.65 liters, 30% after administration of bronchodilator. So this patient would qualify having a bronchodilator response, defined as 12% or 200 ml increase. So flow volume loop also shows severe abnormalities consistent with obstructive airway disease, and the peak expiratory flow is lower than the predicted. So this is the peak expiratory, actual peak expiratory. So all of them indicate bronchodilator responsive obstructive disease. The 60-year-old and presents primary care provider with complaints of increasing dyspnea and exhaustion. He has a 45-year history of smoking and is retired following career as building contractor. FEC is grossly low, FEV1 is low, FEV1 to FEC ratio also low, TLC is increased more than predicted. TLCO is also reduced. So what is the difference?
Obstructive.
Clearly, yeah. Yes, why is hesitation? FEC is only 40%. So this is a severe airflow obstruction. Okay. The patient meets the criteria for reversible airflow as FEV1 and these things are post-PD also is given. So they are improving very well following administration of a bronchodilator. In addition to the abnormalities on spirometry, the patient has markedly elevated residual volume. The RVC is almost 37 is the predicted 76, and finding is indicative of air trapping. And the total capacity is somewhat elevated, 117% of predicted, but is still shy of 120% predicted, used to define hyperinflation. So this is not a case of hyperinflation, but it is a case of air trapping. So severe obstructive disease with air trapping is the answer for this case. And this DLCO also is corrected as slightly low. So carbon diffusion problem is also there in this case. And the 25-year-old presents to the physician with complaints of wheezing. He is a non-smoker. 2 years ago, he was in a major motor vehicle accident and was hospitalized for 3 months. He had a tracheostomy placed, but because he remained on the ventilator for a 7 weeks duration, his tracheostomy was removed after 2 months of discharge, and his PFT is showing like this. FVC is almost normal. FEV1 is normal, reduced, slightly reduced. FE1 to FEC ratio is 54% of predicted 85. And this is the flow volume loop, which you saw in the earlier slides.
Tracheal stenosis, fixed upper airway obstruction.
Fixed upper airway obstruction. Very good. So this patient had airflow obstruction is also there because FEV1 is reduced. Even though FEC is normal, FE1 to FEC ratio is also reduced. So he has an airflow obstruction, but it's a mild airflow obstruction. So in order to make the correct diagnosis, we have to go only for the flow volume loops here. This flow volume loops through the pattern. So this is the fixed obstruction pattern. What is this pattern? These two. Normally given in all the books, whenever you talk about the airway obstruction because of mechanical causes.
Upper airway obstruction.
Is,
when you say there is a fixed obstruction, what could be the other variants? Who is in my answer, in my questioning itself? Variable obstruction. Okay, so this is a fixed obstruction where both inspiration and expiration are obstructed. So we call it as a fixed obstruction. When you say variable, during one phase the flow is normal, during the other phase it is obstructed. Then you call it as variable airflow obstruction. And this can be either intrathoracic or extrathoracic. So which one is intrathoracic, which one is extrathoracic?
second one is intrathoracic.
When you have extrathoracic obstruction, the inspiration is obstructed. You can see this one. See, this is the inspiration is very much reduced. This is normal inspiratory pattern. So inspiration is reduced, whereas the expiration is normal. So EI, extrathoracic, inspiration is affected. Intrathoracic, expiration is affected. So remember like that. E opposite I opposite E. So extrathoracic obstruction, inspiration is blocked or obstructed, expiration is normal. Intrathoracic obstruction, expiration is affected, inspiration is normal. Okay. So this is the fixed obstruction. This is variable obstruction extrathoracic where inspiration is affected. This is variable obstruction intrathoracic where expiration is affected. Okay. 41-year-old woman presents with general internal medicine clinic with 10-year pack history of smoking, history of using intravenous drugs including heroin and Ritalin. Pulmonary function tests are FEC grossly reduced, FEV1 grossly reduced, FEV1 to FVC ratio grossly reduced, TLC normal or slightly raised also. So, the RV to TLC ratio also raised. TLC also reduced. What is the interpretation?
Obstructive lungs.
Severe obstruction. TLC is normal or raised. So RV is also raised. So some amount of air traffic. And DLCO is also reduced. So has something to do with these things, heroin and Ritalin. So airflow obstruction is there. CE1, FEC, all are decreased. Their airflow volume demonstrates characteristics, scooped out appearance. And this is classified as very severe obstruction. Okay, and the RV is very much increased. So this is a hyperinflated because TLC is also very much raised. And it's only the 41% to have 41-year-old person to have an obstructive disease with a 10 back-year history of smoking. So asthma is an unlikely diagnosis given the absence of reversibility. There is no improvement after post-bronchodilator therapy. It is the same. So there is a marked hyperlucency decreases, suggesting this is a basilar phenomenon from emphysema. So this is the X-ray that is seen here. So severe obstructive disease with air trapping and diffusion defect is the diagnosis that we have to make. So these are the things that we have to keep and remember in your mind to ensure that you are able to interpret these patterns in the exam correctly. So remember the pattern for obstruction is FVC reduced, FEV1 reduced, FEV1 to FVC ratio reduced, TLC normal. This is obstruction. Restrictive, FVC may be reduced, FEV1 may be reduced, but the FEV1 to FVC ratio normal, TLC is low or reduced. That is restrictive. So if reduction in FEV1, FVC, FEV1 to FVC ratio with the reduction in TLC, it is a mixed pattern. So it is as simple as that. So nothing to get confused. So hope you will be able to use that knowledge in the exam. I think we will stop here. It is 15. We'll see the X-rays and their ECGs in class. Any doubts or any questions on that?
No, sir.
Okay. We'll sign off.
Thank you very much, sir. Thank you. And a small announcement
you,
about
sir.
the Saturday class, sir. Coming Saturday, we'll have a clinical case discussion at 5 p.m., sir.
Yeah. Yeah, we'll have that.
Okay, sir. Thank you, sir. Thank you, students. We'll